I hope everyone had a great day yesterday, learning new things and meeting new colleagues, and an excellent time last night enjoying New Orleans, but not too much. Yesterday, we heard about critical issues facing the aging network and how the Administration for Community Living and key organizations are forging initiatives that will really look at focusing on the critical services that AAA's and Title VI programs do, responding to elder abuse, supporting caregivers, navigating workforce challenges, and enhancing the capacity of the Aging and Disability Network. Whew, that was a lot. This morning, we're going to delve a little deeper into some of the drivers of change that are impacting the health and well-being of older adults, people with disabilities, and their caregivers. Before we dive in, this morning's session wouldn't be possible without the support of Aetna. Aetna Medicaid, a CVS health business, is pioneering a bold and new approach to total health, making quality care more affordable, accessible, simple, and seamless, and not only giving help to people, but also helping them stay well in their body, their mind, and their spirit. Aetna Medicaid has honed its approach to serving high acuity, medically frail, and low-income populations with diverse benefits, including those that are for the duly eligible for Medicaid and Medicare and long-term services and supports. They understand, like us, that each population is unique with unique service needs, and they are committed to collaborating with state agencies, members, providers, community-based organizations, area agencies on aging, and other stakeholders to provide excellent service to each of them. By bringing these strengths to their Medicaid members, they provide the framework necessary to be a good partner to AAA's and improve the lives of our nation's most vulnerable populations. While we be joined today by Tina Griffith from Aetna on this morning's panel, I'd like to ask all of the Aetna representatives who are in the room to please stand so we can thank you and Aetna for your supporting n4a and for this morning's fantastic session. So Aetna friends, please stand. We really, really appreciate all your support. And now, on to our exciting session, focusing on the drivers of change in bridging healthcare and social services. We're seeing that increasingly, healthcare providers and payers have begun to recognize the importance of the social determinants of health, such as food, transportation, housing, to improve the overall health and lowering healthcare costs. The healthcare sector is starting to understand and appreciate what we've known for years, that the services and supports that you provide make a difference. We now have increasing evidence that great things can happen when social services and medical providers team up to coordinate and integrate the care that they deliver, addressing not only the clinical needs and issues of older adults and their caregivers, but also tackling the social determinants of health and community living needs that impact an individual's holistic well-being. When the medical and social fields come together in a meaningful and a sustainable way to support true population health, care quality improves, cost savings accumulate, and people are empowered to live more dignified, independent lives in their homes and their communities. We know many of you are already capitalizing on these opportunities and engaging in business arrangements with healthcare entities to work together in addressing social and behavioral needs in addition to medical care. But we also know that pursuing a new way of doing business doesn't come without challenges. n4a's Aging and Disability Business Institute is here to help. The Business Institute is led by n4a in partnership with experienced and respected partners in the Aging and Disability Network. Together, these organizations provide community-based organizations with the tools and the resources needed to successfully adapt to a changing healthcare environment, enhancing their organizational capacity and capitalizing on emerging opportunities to better coordinate care for older adults and people with disabilities. We know that building the business capacity of AAAs and other aging and disability CBOs, enabling them to effectively contract with healthcare payers, will ultimately lead to improved quality of life for older adults, people with disabilities, through better integration and coordination of a wide array of medical and social services supports. I'd like to thank the Business Institute funders who recognize this important part of our mission. We're grateful to their leadership. We're grateful for their support. This effort is led by the John A. Hartford Foundation, along with the Administration for Community Living and the SCAN Foundation. These funders have joined together to provide N4A and its critical partners with the funding necessary to launch the Aging and Disability Business Institute, which has enabled us to expand our efforts to provide training and technical assistance to aging and disability community-based organizations to help us partner and contract with healthcare entities, to provide integrated supports, and to build age-friendly health systems and communities. And these efforts are paying off as we look at most of the recent results from the Business Institute survey. What we know, and Marisa talked about it yesterday in the opening general session, we know that 41% of the responding AAAs have contracts with healthcare. More than half of the responding AAAs either have contracts or pursuing them, and more are jumping in and jumping on board every day. We're delighted to have with us to start this general session Rani Snyder, the Vice President for Programs at the John A. Hartford Foundation, one of N4A's most valued partners in helping aging and disability organizations partner with healthcare. Located in New York City, the John A. Hartford Foundation is an organization dedicated to improving the care of older adults. Established in 1929, the foundation has a current endowment of over $560 million and is well renowned for its philanthropy devoted exclusively to the health of older adults. Rani Snyder is Vice President, as I mentioned, of Programs at the Hartford Foundation with over 25 years of experience working with preeminent healthcare institutions across the nation, improving the care of older adults, identifying and guiding healthcare programs that have set the standard for medical best practice, increased medical educational opportunities, and maximizing resources to improve healthcare broadly. She brings that experience to the John A. Hartford Foundation, where she coordinates initiatives that foster collaboration among academic institutions, hospitals, medical providers to build age-friendly health systems that support family caregivers and improve serious illness and the end-of-life care. She's also the chair of the Board for Grantmakers in Aging, a membership organization comprised of philanthropies with a common dedication to improving the experience of aging. A fellow at the New York Academy of Medicine, and previously served as a volunteer long care ombudsman for the state of Nevada Aging and Disability Services Division. This is a champion for aging programs who represents aging both at the national level, but as you can tell, serving as an ombudsman, she also knows how to provide services at the local level as well. Please help me and join in welcoming to the stage Rani Snyder.
Good morning. Thank you, Sandy, for that warm introduction. That was really lovely. It is a pleasure to be here. It's a pleasure to be here because this is a group that's doing such critical work that we are so, so proud to support. As Sandy mentioned, I'm the Vice President for Program at the John A. Hartford Foundation, and she gave you a little bit of an overview of what we do at the John A. Hartford Foundation. We are a private philanthropy based in New York City, but we operate nationally. And as she mentioned, we were established in 1929 by the family owners of the great Atlantic and Pacific Tea Company, perhaps better known to you as the A&P Groceries. We have had a program in aging and health since 1982. And during that time, since that time, we've authorized over $500 million in funding to support aging and health. The history of our work has been largely built on building the field of aging experts and testing and replicating various models of innovation. Sandy shared with you our mission and priorities. Our mission is dedicated to improving the care of older adults broadly, and we have these 3 areas, and the point I want to make here is how much these areas are integrated with each other. Building age-friendly health systems, supporting family caregivers, and improving serious end-of-life care. Now, I live in New York, because that's where the John A. Hartford Foundation is. But like so many of you, I've lived in a number of other places. I've lived in Rhode Island. I lived in California. I spent a number of years in Nevada. But I grew up in Maine, and my family's still there, and that's still home to me in many ways. So when I had to go to Maine just about 2 weeks ago on business for a site visit that we conduct, I decided that I'd really like to step in the door of one of the AAAs there and spend some time learning about what they do. So I went to the Southern Maine Agency on Aging. And that was an appropriate place to go, not only because it feels like home, but also because they were the winners of the first John A. Hartford Foundation N4a Innovation Award. They were nominated by Maine Health's Accountable Care Organization. So I went there, and I visited with their leader, Larry Gross, and I said to him, you know, Larry, I want to, like I said, walk in the door and kind of see and feel and touch what it is that you do every day. I want to understand the work. I would like to see the array of services that you provide, and I want to hear stories. I'm really interested in hearing stories of the people who you serve. And I got those. He introduced me to many of his staff, at least one of whom should be in the room. And I met, among other people, with a woman named Meredith Anderson, who shared with me a story that I want to share with you. This is about a 66-year-old man who came to the Southern Maine Agency on Aging office as a walk-in. He was living in his van with his dog, and he was doing odd jobs, which generated enough income to pay for his food, his dog, and his van. This gentleman came to the agency for assistance because he had experienced a medical event, and he was no longer able to work. So the scaffolding that he had built to keep himself afloat was coming down around him. This individual had no income, he had no insurance, and he had no shelter other than his van. So at the agency, the resource specialist assisted him with contacting Social Security in order to start receiving his entitlement. She helped him apply for SNAP and for Maine Care benefits, and also to complete his Medicare enrollment. After establishing Maine Care and Medicare, including prescription drug coverage, he was able to connect with a physician and receive the medical attention that he needed and the medication that he needed for his condition as well. But it didn't stop there. She also completed affordable housing applications with him. After having been on housing wait lists for many months, he is now about to move into his own apartment. So he's scheduled for a surgery to treat the medical condition for which he could not get help before, and he's expressed enormous relief that he will soon live in a safe, comfortable place where he can recover. So this is a human story. This is a success story, clearly. This is a story about the integration of the social determinants of health and the health care together. And this is a story about the kind of work that you all see and do every day. So I really wanted to start with an acknowledgement of the personal impact that you all have every day and how enormously grateful we are at the John A. Hartford Foundation, and how incredibly meaningful that is, as I launch into a few words about arenas for action that we think about at the John A. Hartford Foundation. I'm going to talk today for just a few minutes about 3 different arenas for action: healthcare, social needs, and public health. And think about what drives change in those 3 areas, some of the things that we've been really thinking about and working on, and how these 3 arenas come together. The first is healthcare. And thinking about older adults, what's really meaningful about healthcare? Well, there's demography. The population is rapidly expanding. There's complexity. If you think about the complexity of many of the older adults in our population, it includes chronic conditions, it includes functional needs, and often advanced illness as well. Disproportionate harm. Older adults too often experience harm from healthcare that is preventable. So there's lots of evidence-based practices and geriatrics models of care that are proven to be very effective, but they reach too few people, only a portion of those who could benefit. They're difficult to disseminate and scale. They're difficult in settings with less resources, and too often they don't translate across care settings. So we think about the drivers of change, and we have chosen to adopt a game-changing aim that we call age-friendly health systems. The idea is to build a social movement where all care for older adults is age-friendly care. It's guided by an essential set of evidence-based practices, the 4 M's that I'll talk about in just a moment. It's about causing no harm, that disproportionate harm that I mentioned on the last slide, and it's consistent with what matters to older adults and their families. So our aim with age-friendly health systems is to reach 20% of the U.S. health systems by the end of 2020. So this is a little bit of information about the age-friendly health systems and the framework. The components of these 4, sort of like the components of our 3 areas at the John A. Hartford Foundation, are synergistic, and they reinforce each other. They impact key quality and safety outcomes, and we call them the 4 M's. The first M, always the first M, is what matters to the older adult and their family. It's aligning care for older adults with their specific health outcome goals and their care preferences. Next, medication, using only medications if necessary that don't interfere with patients' care preferences, with their mentation or with their mobility. Third is mentation, and that's preventing, identifying, treating, and managing dementia, delirium, depression across all care settings. And last is mobility, and not last necessarily in order. The only thing we put in order is what matters first. But mobility includes ensuring that older adults can move around safely and daily, on a daily basis, to maintain their function and also their care preferences. So there's only 4 of them. It's sort of easy to remember. They're a set. They come together. And the framework is really about simplifying and reducing implementation and measurement burden while increasing effects. And it builds on a very strong concept of the triple aim plus evidence. This is just a snapshot of where we are in the age-friendly health systems implementation. It is indeed on the rise. We're right now at 126 systems in 357 sites in 37 states. So chances are good the state you're in is one of those. The next arena for action is social needs. This is where you live and where you build linkages. I don't have to tell you about what those social needs are. You know it, you live it every day, as the example that I shared earlier. Food, housing, mobility, transportation all have an enormous impact on our, oops, I didn't change the slide, I'm sorry, on our health and well-being. In addition, high-functioning communities increasingly are where social services and healthcare think and act together. We think about this in terms of both rural and urban spaces. So what have we done how do we think about driving change in terms of social needs? Adopt a game-changing aim. With N4a, build community and health system partnerships. This is the work that Sandy mentioned. This is the N4a Aging and Aging and Disability Business Institute, whose goal is to advance integration, partnerships, and importantly, payment models between social services and health systems. The payment options include the Chronic Care Act and Medicare Advantage coverage for health and health-related social needs. You all know this. The Chronic Care Act updates fundamental principles of the Medicare program by allowing Medicare Advantage plans for the first time to pay for services that are not primarily health-related, and to target these services toward meeting individual needs. This is going to be a game changer. It expands what qualifies as a supplemental benefit to meet the needs of chronically ill Medicare Advantage beneficiaries. The third arena for action that we're thinking a lot about is in public health. Public health is partly responsible for the dramatic increase in longevity that we all see in our clientele, in our understanding of the importance of older adult. But historically, limited public health focus on older adults and limited collaborations with healthcare systems and aging sectors have been the norm. Over the past 50 years, it's been rare for local, state, or federal public health agencies to dedicate funding or develop initiatives targeting older adults who are age 65 and older. Although state and local public health programs distribute things like seasonal influenza vaccines and offer some programs for balance and diabetes and nutrition, which are really important, and they may reach older adults, virtually none of the state public health departments have a specialized division focused on older adults. And despite the growing demographics that we are also aware of, public health departments are still more likely to attend to maternal and child health and to infectious diseases than they are older adults and the chronic illnesses that they present. So what's our driver of change? Adopt the game-changing aim of age-friendly public health. Public health's contributions to our longer lives now needs to also focus on adding quality to those years by doing the things listed here, by promoting healthy aging, by reducing social isolation, ensuring mobility and access to healthy, affordable food, and emergency preparedness. I love this photo. This is a photo of Sarasota Beach's Moby Mat for older adults to ease mobility so that all ages can enjoy it. And you'll see, this is not a photo of older adults. And the point I want to make related to that is that so often, what you do that's the right thing for older adults is the right thing for our communities, including and beyond older adults. So right now there's a pilot. We're working together with Trust for America's Health on this pilot of a Florida-based age-friendly public health model. The pilot is assisting local public health departments to assess and address the needs of older people with aging as the lens for their planning and their strategy. And later, we intend to engage other states as well and the nation in defining and providing age-friendly public health. You'll hear more about that later. So, thinking of our three arenas and the drivers of change broadly, this is what I was talking about originally with advancing an age-friendly social movement. There are a number of arenas: age-friendly health systems, age-friendly communities, age-friendly public health systems, and age-friendly cities, but that's not all of it. This is even broader than that. There's an age-friendly world movement, livable communities. In 2006, the World Health Organization established the term age-friendly, as in age-friendly world. And now in the US, AARP is driving the cause. 4 states have signed on so far and committed to becoming age-friendly. Those are New York, Massachusetts, Colorado, and Florida. And I only hope there are more coming up behind. Age-friendly communities provide safe, walkable streets, housing and transportation options, access to needed support services, and opportunities for all ages to participate in community life. These are the communities we want to build. These are just some of the stakeholders with whom we're working. There are many more, and there are others coming really, it feels like every day. This has really taken off, and so we're so proud to be a part of it and to be partnering with all of these and many more organizations. So I want to end by talking about the drivers of change that is all of us, all of you. We see age-friendly as a social movement that starts at the kitchen table, goes out into the community, whether it's healthcare, whether it's community-based organizations, and comes right back to the kitchen table. That is age-friendly health and age-friendly care. Our goal is to create a world where older adults prosper and flourish in rural and urban places, in cities and states, in the justice system, in government, business, health, community, and community-based organizations, and public health as well. So I want to end with this. Thinking about age-friendly care and age-friendly health systems, repeat after me. I deserve age-friendly health systems. And even louder, I demand age-friendly health systems. Thank you. So I'm really excited to bring the panel up to the stage to talk to all of you about the work that they're doing along these really important lines. So I'm going to call up each individual and let you know who we're talking to this morning. And first is John Auerbach, President and CEO of Trust for America's Health. Hi, John. Bruce Chernof, President and CEO of the SCAN Foundation. Gary Cook, President and CEO of the Direction Home Akron-Canton Area Agency on Aging. Tina Griffith, Healthcare Equity Director of Aetna Better Health of Louisiana. I just want to share that Tina's commute this morning was 1 mile. And Steve Janicak, Division President of Healthcare at Tivity Health. How's the mic? No? Is the mic on? Oh, hello. Now I'm yelling at you. So thank you all for joining us this morning. I'm really excited for this panel. We thought a lot about the kinds of questions that people would have and the kinds of information people would want to understand. And I really have 2 lines of questions for you, and individual questions based on where you're coming from and what you're doing. And the first is along the lines of the policy drivers of change related to healthcare, aging, and social determinants of health. Thanks to the Bipartisan Budget Act of 2018 and the Chronic Care Act, as well as the Centers for Medicare and Medicaid Innovation's value-based insurance design models, we see the beginnings of so many really critically needed changes in the Medicare program when it comes to addressing the social determinants of health for Medicare beneficiaries and those with chronic needs and functional impairments as well. So Bruce, I'm going to ask you first. Tell us about the work that the SCAN Foundation has been doing to develop guiding principles for the new Medicare Advantage supplemental plan.
Wonderful. So good morning, everybody. Thank you to n4a for having us up here and a wonderful opening set of remarks, Rani. I think we really believe that we're at the cusp of an important change. So I lovingly say that Medicare Advantage was sort of purpose-built for 1972, and it hasn't really changed very much since then in many ways. I mean, yes, we have Medicare Advantage, and yes, we have Part D, but the reality is people are living so much longer, as you all know. And when Medicare was created, the average life expectancy was 69, and now people live well into their late 70s or early 80s, and we're much more likely to live with needs that you all understand very well, but as a physician, I can share with you, healthcare systems have little understanding for. And Medicare, by extension, has had little understanding for. So as Rani suggested, the Chronic Care Act and the budget amendment of last year, for the very first time, created a platform for home and community-based services, specific services, to be targeted to a subset of high-needs older adults. So that's a really important frame. It has some really important limitations. So it's Medicare Advantage only, not fee-for-service. It is a supplemental benefit, which means plans have to choose to offer it. It's not part of the core Medicare benefit. And there's a limited set of potential benefits. So it's things like transportation, meals, care coordination, and home modifications. It's a great start, but you all know that that's not everything in the lives of older adults and their caregivers. And so we brought together thought leaders from across the spectrum, because what we wanted to do was to get folks in the room to talk about what it would mean to implement these in Medicare. So major health plans, some of whom are up here, advocacy organizations, health systems, researchers, other foundations, folks from CMS. What is it going to mean to implement these things successfully, particularly because they're supplemental and therefore optional at some level. They're not a required benefit yet. And we came away with 5 really important principles. So first, we have to put older adults first, that their needs have to drive how services are organized. So that means that things have to be individualized. Second, we need a way of helping older adults and their circle of support understand that these are options and make good decisions about what works for them. Third, we really do need these to be equitable. So it's very important that we begin with the place of if we're going to offer them, they're offered equitably by the Medicare Advantage plans. But there's a larger discussion about equities, right? So how do we get these resources out to others? Then we, as the next principle, we think it's really important that these evolve over time. I mean, there's very important questions. Why only these benefits? Why aren't they available in other forms of Medicare, even in advanced payment models, or alternate payment models, ACOs, and other settings that touch more fee-for-service oriented environments? And finally, they need to be sustainable and manageable. So for the plans that have to offer these, they need some belief that there'll be consistency from CMS, that if they start down this path, if they work with all of you, that the rules aren't going to change a year or 2 from now. So we got almost 3 dozen organizations to participate. Every single participating organization signed off on the principles, and we look forward to pushing these forward as CMS thinks about implementation and development.
That's really important, and you've done such great work in that area. Thank you for that. So Tina, tell us a little bit about what Aetna is doing to respond to the kinds of changes in Medicare Advantage that Bruce has described.
Yeah, so when you consider addressing health-related social needs of beneficiaries with chronic conditions and functional impairments, you're really looking at those social determinants of health, right? So you're looking at transportation, housing, food, and safety. So then you're looking at, well, what kind of programs and initiatives can we put together that could address some of these social needs? So one of those is Resources for Living, which is actually a concierge service for a population, and what they have the ability to do is call up and access local resources, right? So if you're looking at what's available locally, you're really connecting that person to something that is in their community, right? So with Resources for Living, you're able to call up and ask for help with your home. So you might need yard work, you might need help with cleaning. You have the ability to connect to caregiver support. You also have the ability to connect to social activities. So whether it's like volunteer opportunities, recreational opportunities, social classes for skills and interests, things of that nature. So I think it's really what kind of innovative and creative way can you connect your population to something that they really need?
That's very interesting.
Also, I'd like to add that, you know, in some of our markets, we have Meals on Wheels, right? So when you think about some Meals on Wheels programs, you have the ability to connect those individuals not only to a nutritious meal, but to social support, to safety checks, to other things that they are really, they might need to access.
And you're building those into communities.
Correct.
Fantastic. So, Steve, you're here representing Tivity. How is Tivity responding to the changes in health and nutrition programs?
So, if I could just clarify, everybody knows us, we're Tivity Health, but mostly people know us by Silver Sneakers. So we do a lot of work with Medicare Advantage plans and a lot of the folks in this room as well. So what is interesting with the changes that have happened with that Bruce and Tina were talking about, what we are able to do is we're taking those and kind of implementing and making stuff actually work. So the primary foundation of our business really is around physical fitness, is where we started. So we have a network of physical locations. We have what are called flex locations, where we actually have some of the agencies where we run classes and get people active from that standpoint. Well, that is where we started, and then as all of this started to change, and as we work with Medicare Advantage plans, our customers were asking us, We need help on other things. We need help with nutrition. We need help with some of our diabetics that are on chronic conditions. We need help with obesity. So that led us into the nutrition environment, which then in December of last year, we made an announcement where we actually acquired Nutrisystem. So what we're able to do is to bring to our health plans the ability to not only get the physical activity component going, but also addressing the weight loss and then managing the diabetics as well. So as these changes are happening with the Chronic Care Act in allowing them to specifically focus on certain populations, we're now working with those plans to be able to focus on starting with diabetics first, a lot around social isolation, which we'll talk about a little bit later. But that is enabling us to do it, and that acquisition allows us to be able to offer more to help older adults in general.
I love that you're branching out. It's
We are
good for
branching
everyone.
out.
John, public health is a little bit of a different animal. Tell us a little bit about the opportunities and how public health fits into these payment models.
Sure, thanks, Rani. Well, we're talking now about the social determinants of health, and we're talking about the needs, as you said earlier, for housing, for food, for transportation, safety, a bunch of services that are important. And having the opportunity that we're talking about for CMS to pay in Medicare Advantage and Part D plans for some of those services is really important, and Bruce talked about some of the ways that we should take advantage of that. But from a public health perspective, we really think of those services as being part of a continuum that stretches from screening patients for their social determinants, that's in a clinical setting, but then also, once the needs are identified, ensuring that the services that people need are available. In the absence of working at that wider community level and the policy level, some clinicians have characterized this as the danger that we're building a bridge to nowhere, in that we're identifying the need, we're reaching out, but there may not be the services that people actually need in the community. So I'll give you the example of housing. Probably the number one issue that comes up in terms of social needs and the screening of patients is housing and stability and affordable housing options for people with the right kind of service wraparounds. But if you look at the availability of affordable housing in most communities, it's very limited and insufficient for what people need. In Florida, we had an example where people waited for days, not hours, but days in line. Older adults and people with disabilities, to apply for a few hundred of the available affordable housing units. Most of those people did not get the housing, and some of them will wait for years on those lists. So what we would do from a public health perspective is really think about what are the policy changes that are necessary. How do we think at a municipal level, perhaps a city level, around how do you create more affordable housing through a variety of different legal and regulatory approaches. The same thing's true with the transportation systems. Those aren't just about the individual trips that people may need to the doctor's office or to the grocery store, but just how do you have a transportation system that makes it easy for people to travel so they're less likely to be socially isolated. So public health, I think, is a wonderful partner to the area agencies on aging, because you also think about those larger community issues. But public health, I think, can be a partner in terms of thinking at the global level, change the policies, make the larger communities age-friendly, make public health age-friendly so it can complement the opportunities that exist now in clinical care.
Oh, that's wonderful. I love the broad, systematic community focus that you're describing. So Gary, these are your people. Talk a little bit about what you see as the opportunities for AAAs and community-based organizations with these Medicare Advantage changes. You know, how is your agency responding?
Well, I think there's been a couple things. For instance, one of the buzzes of the conference is the comment about Blockbuster, right? So I think those of us in this room have to decide what we want to be. Yeah. What do we want to be? And I think there's an urgency there that if you don't want to be the right thing, you aren't going to be at all. So historically, area agencies on aging across the country have been extensions of government. They've been, some of them are governmental organizations, many of them are nonprofits, they're in private companies, but by virtue of all of their contracts coming through governmental sources, they're extensions of government. That's a huge culture shift to now say, now we want to be entrepreneurial, we want to be risk-taking, and we have to be willing to do that. We still want to pay tribute to our core of Older Americans Act responsibilities and those kind of things. At the same time, we need to be entrepreneurial. So right now we have a remarkable opportunity with Medicare Advantage, but even broader than that, to frame the issue. So Medicare Advantage plans, we have a great relationship with Aetna in Ohio through our Duals Demonstration Project, the area agencies. We have an opportunity now. We finally have an acknowledgement that social determinants of health impact health outcomes and lower costs. We in this room have known that for decades, but there was never any common acceptance of that. Now it's dogma, right? Everybody knows and agrees to that. So now we have some funding mechanisms that allow us to try to make that bridge between healthcare and community-based care. But nobody really has figured it out. And I mean the Medicare Advantage plans haven't quite figured it out, the health systems haven't figured it out. So this is an opportunity for those of us in this room to say, what are our core competencies? This is our wheelhouse. How can we bring those core competencies to the Medicare Advantage plans in a way that makes business sense? And therein lies the big question mark. We know functionally that we can provide things that impact the social determinants that'll lower your costs and provide better health outcomes. So it's incumbent on us to say, what kind of business models can we use to go to the Medicare Advantage plans and frame the issue for them? Don't let them figure it out. Let's figure it out for them. So we've got some things I think that we'll probably talk about in a bit.
Great. I know you've done pioneering work in this area and have a fantastic network in Ohio.
Sometimes better be lucky than good.
So I'm going to turn now from this policy discussion and think a little bit more about individuals who have very complex chronic needs. Whether that's due to chronic conditions or functional needs or advanced illness more broadly. So thinking about how is meeting the needs of that population driving systemic change in healthcare and in long-term services and supports. And I'm going to start with you again, Bruce. The SCAN Foundation, together with the John A. Hartford Foundation, are part of the Six Foundation Collaborative. We call it 6F, working together on a Better Care Playbook that is designed to improve the health outcomes and the daily lives of people in the U.S. who have complex care needs. Tell us a little bit more about the initiative and where community-based organizations fit into it.
Absolutely. So picking up just on a second what one of the things that Gary said that I think is really important, and I think one of the things that the John A. Hartford Foundation and the SCAN Foundation both believe is that we need health systems to think differently and be better prepared. We fundamentally believe in aging networks and their ability to transform, still honoring where you've come from, but really needing to change. And what you articulated that worked for me so well is this idea of, like, you guys have the secret sauce in this room. You own the secret sauce, since we're doing franchise chains as the theme of the conference. And you shouldn't be giving it away to health plans and health systems. They don't need to be in your business. They need to see you as effective business partners. And so we really believe, I think, in the work of the Aging and Disability Business Institute as a way of skills building. Right? That's an example. So it takes two sides of the equation to really get the outcome we want. That's one piece of it. The other piece of it is that we, along with our colleagues at Robert Wood Johnson, the Commonwealth Fund, the Peterson Health Institute, and the Milbank Memorial Fund, we really came together with a shared realization that there do not need to be any more pilots about models of care that could actually make health systems more effective in improving the healthcare outcomes and lives of older adults. There's 25 years of work. We lovingly call those in our foundation the John A. Hartford Foundation's greatest hits. There are lots of models that are out there, and really the question is, why aren't those models more available? And why aren't they better able to participate and contract and relate effectively to all of you and other community-based providers? So the playbook tries to do a couple of things. First, it really captures those models, what's known about them, but it also lays out how a healthcare system, a Medicare Advantage plan, a hospital system, a medical group could actually pull down one of those models and start to implement it in their system, including partnering with organizations like all of you. I think the other thing that we fundamentally believe in is that we're going to need to help bring people along. So just like the work we're doing with all of you in the Aging and Disability Business Institute, that it's very important that we create environments where plans can learn from each other and where ACOs can learn from each other so that it isn't reinventing the wheel over and over again. So the 6 foundations have started to collaborate on helping with uptake, potentiating generalization, and creating more avenues for all of you to participate, because what we really need is better outcomes in the lives of older adults, and we will not get there just chasing diseases. That is not the answer.
That's really helpful. And you know, we also realized as funders that no one of us can do it alone.
Right.
And so it's been a really lovely way of collaborating in new and very exciting ways. Gary, I'm going to go back to you. AAAs have been working in this space with people with complex care for decades. This is your bread and butter. But there is now a renewed effort to integrate the healthcare and social services sectors to provide that holistic, person-centered care that we think and talk about so much. How are the delivery system reforms that are happening right now changing the way you do business?
Well, one of the things that when you approach, how can we help and bringing people along? Well, people is a lot of different groups. People as physicians, people as health plans, people as executives, people are hospital administrators. So we have to bring all of those groups along. And the way you do that is by little bite-sized pieces. It's not a major announcement that here's. So you have a strategy to deal with physicians. You have a strategy to deal with hospital executives. And you have to come up with the forums that you're going to do that. CCTP, for instance, those of us who did that, allowed us, because the partners in that, even though the main contracts went through the community-based organizations, you had to have multiple hospital partners. In our case, we had 4 different hospital systems, 12 different hospitals in our regions. Those guys didn't like each other, right? Those hospital systems are cats fighting for market share. But we brought them all together, and in so doing, and had great outcomes for them, but in so doing, we increased the level of, respect isn't the right word, but the level of acknowledgement that we were a competent, successful organization that could help them. Building on that then, CCTP went away, but building on that, those relationships, those collaborations, we are now working on other things where they're now beginning to conceive of us as a resource. Whereas before they might not have even conceived of a resource. They might have thought it's better for me to build it than to buy it. If I want to do social determinants, I'll set up a division and I'll work with our internal home health agency and I'll do that. But it doesn't work as well. We had this chief medical officer for a Cleveland Clinic Hospital in Akron say, wow, you guys are one-stop shop. You're aggregators of services, right? We have 300 community-based organizations under our contract that we can refer to, for a variety of other things that we contract with. You can call us and we can connect you with so your discharge planner who doesn't have all those resources. So that's another example of a relationship. We have a program to educate physicians where we bring in physician residents and works through the local medical school, NeoMed. We bring in the physicians, and the physicians get the little dog and pony show about what we do, and they go, wow, this is great, I didn't know all this stuff was out there. But they also bring in complex cases. And they bring in those cases and we ask them to ahead of time, and they say, geez, I ran into this case where I couldn't figure out what to do with this person. So we have we discuss those in their education, and those cases become legacies for the next physician group that comes through, and we can review those. We have a program called CMET, Case Management Interdisciplinary Team, where we bring in physicians, pharmacists, whoever else we need, with our case managers to talk about complex cases. All of these things have a multiplier effect and are just examples. I mean, we do a lot of other things, but they're examples of how we can get our ability to help with complex cases, that information out to hospitals, physicians, Medicare Advantage plans, et cetera.
You know, so much of everything you just said really speaks to the importance of building and nurturing those relationships, how important the relationship, the understanding, and the trust is between the work that you do and the health systems that you can educate. That's very...
It's all based on relationships. You need to develop those relationships at whatever the target organization is, whether it's a Medicare Advantage plan, whether it's a hospital system, whatever it is, you need to develop those personal relationships. They need to know who you are.
Absolutely. I'm going to turn to Steve. Steve, Tivity Health is highly respected for so much of the work that you do, including work in rural areas, and now also as you branch out into older adults with complex care needs and thinking about how to serve them in terms of social isolation. How's Tivity providing leadership and innovation around social determinants of health and around social isolation?
Sure. So this actually is my first N4a conference, and it's been fascinating to me, and I met so many great people. But the fascinating part is to be able to see what's happening from a policy perspective, what some of the foundations are doing and what some of the agencies are doing, and then what we're focusing on is actually implementing some of those and having impact. So one of the things that we've taken on as an organization is we have now gone to the point where we have said social isolation is a chronic condition. There was research that was done that came out that said a socially isolated senior and medical impact is the equivalent of smoking 15 packs of cigarette a day. So what we're doing is we're partnering with a lot of our clients, and one of them in particular is Humana. So we're doing a pilot program with them, and we're working to do a published study where they have done an algorithm where they can identify people that are, quote, socially isolated or potentially socially isolated. They send that data to us, and then what we do is we outreach to that member, and we engage them. We engage them in a conversation. We talk to them about what's going on, and the goal is to get them to go to a facility to do something. It doesn't necessarily have to be physical activity. It could be the social aspect of it. It could go to a Y and play bingo. Just get out of the house and go do something. And then they're going to measure the medical impact on the claims as well as their healthy days throughout the course of the year as a result of that. One of the other things, prior to me taking this job here, I was not involved with seniors, but I saw firsthand the impact of social isolation. I was a caregiver for my parents, and my father got put into a nursing home, and my mom was trying to live at home on her own, no relatives where we were around. Most of her relatives had passed away. I went over to her house one day on a Saturday, and she's sitting in the middle of July in Nashville, in the house. All the shades and windows are closed with a coat on and sunglasses. Sign number one, there's something wrong. Actually, she had gotten depressed, so we moved her into an assisted living facility to get her access to people and the social component of it. She literally became the mayor of that place. She went from that to, one day I walked in and people came to me and they said, hey, we want your mom to be an ambassador. And I said, an ambassador to what? And they said, well, we want her to be the person that comes in and talks to people and takes them on a tour. And I looked at him, I said, you talking about my mom or somebody else? But anyway, not realizing it at the time, the impact, but I saw it firsthand, and we are 100% focused on trying to do what we can for all of our Medicare Advantage clients to help.
I think that's so important. And you said one thing that I want to call out. You mentioned Humana wanting to use these basically predictive analytics to target, to figure out who are the people who will most need assistance. And that's coming down the pike. That's where their interests are. And we all should be aware of that as we think about the kind of work that we want to promote and how best to get there to skate to where the puck is going to be.
Yep. Well, it's starting with Humana, but it's also filtering into some of our other clients. So we're also
Absolutely.
working with Anthem is trying to do the same thing. Aetna's starting the conversations around it. So algorithms aren't built yet, but that's where it's going.
That's what they all want to do.
Yep.
So Tina, one of the things we haven't talked a lot about is the way that social and health disparities are experienced by adults in underserved populations and how much it really affects their complex care needs. I kind of have a two-part question for you, so I'll start with the first, which is really just, how is Aetna striving to address those issues to achieve health equity among your members?
Yeah, I think it's really important when you think about health equity and disparate populations within your membership. One thing that you really need to do systematically is look at your data. That's really important. It tells a lot about what's going on in your population. So if you're looking at your data internally and then you're looking at what is happening externally, there's so much public health data out there. Research data, there's local community health needs assessments. There's so many things that you can incorporate into what you're doing with your internal information and then what's available publicly. And if you take those two, you can create this picture of social determinants of health. And then from there, you can look at it and say, if we have all this information and we know we have the voice of our membership, we've engaged them, we know that there are programs and resources out there that we can link them to. So I really think it's very important when you're thinking about an underserved population that you really know what's happening.
That's great. So that's sort of on the Aetna side, and then talk a little bit more, second part of the question, about how you are working together with AAAs and other community-based organizations to help address those needs for the social determinants of health needs of your members.
Yeah, so when you think about some of our collaborations with the AAAs, I'm just going to highlight a couple of different examples for you. So in Ohio, we're fully delegating our case management services. We're also delegating recovery services. We're doing assessments with some of the AAAs. And then also in Arizona with some of the AAAs, we're actually collaborating and doing adult day healthcare. We're looking at Meals on Wheels, care transition programming, behavioral health services. So if you're looking at the entire individual as a whole, that total person, and trying to see what their needs are, you're really going to look outside for resources in order to meet those needs. And that is going to be through collaborations with community-based organizations as well as AAAs.
And have you seen that on the rise in terms of the work that you're doing?
Yes, definitely.
Fantastic. John, so once again, public health, what is the role of public health in this transformation?
Well, with the support of the John A. Hartford Foundation, we're piloting this in Florida now. And what we're finding is that it offers an opportunity to see how the public health system, in conjunction with the area agencies on aging, can work at a municipal level. What does that look like? It looks like pulling people together at a single table, using the authority public health folks report to either the mayor, the county commissioners, the governor. So using that authority to pull people to the table that includes the payers, the largest providers, the AAAs, and other key partners from different sectors. And those sectors need to include transportation, housing, economic opportunities, so they're job opportunities. Aggregating the data that exists across different health systems so you can say, here's what we're seeing at a municipal level are the actual needs. Simultaneously, while the individual patient needs are being addressed in the ways that we've discussed, how do we think about this as a system? That can identify where there are gaps, because we have unevenness across the country. We have places where there's only one health system, and we have communities where there are multiple health systems, and people aren't always working together across those different health system lines. So getting people in a room, using the authority that can come from the elected officials and the public health folks as their representatives, in partnership with AAA to say, what do we do all along the line? If we're finding a gap, if there's a gap that's critically important, who's responsible for that? If the best entity to fill that gap, whatever that gap tends to be, is the area agencies on aging, then I think the case would be not simply relying on negotiating with the payers, the health plans, but also thinking, is there direct funding? Can we make the case that there needs to be direct funding from the federal government, from the local level, from the state, to build those services that are important but are unlikely to be reimbursed, but are a part of solving the problems that we're talking about that patients will be experiencing?
I'm so glad that you in public health are thinking about these issues and aging, because we have needed this for a very long time. And your entry into this space has a lot to offer to all of us. So I'm going to open up questions to all of you. So we've heard a number of different things from different perspectives that I think are incredibly valuable. And there may be some interplay between you in terms of the different places that you come from. So I'm just going to put it out there and see who wants to respond first to the question about looking ahead. What do you see as the future of AAAs and other community-based organizations when it comes to driving change and improvement in our healthcare and our long-term services and supports systems?
I see us as Netflix, not Blockbuster.
That's a great first response.
But picking up on that observation, that's an active choice. So I want to challenge everybody in the room. I really want to thank Sandy and the leadership for bringing us together. That's a really active choice, which I think all of us up here strongly support, but one that needs to be built out over time. It's not going to be perfect every time. Each organization's going to be in a slightly different place. And so I think there is that sort of patience of being willing to do the work and learn. And even though CCTP went away, there was still lots of good learning that came from it. And it really helped me to hear you articulate the success that's come from it, the second and third order effects. I think John's point is really, really important, which is what is the larger role for the aging network in an evolving world? And I worry very much as a physician and as somebody who ran a major health department that we tend to relegate older people to they're either the chronic conditions or they're the palliative and hospice program. And that's sort of how we define older people, which is a very ageist and negative frame. And I think beginning to understand that most older adults live their lives every day kind of the way they want to. And so taking a more strengths-based approach and sort of seeing service delivery as part of the fabric of a community, including the role of public health, right? To not just sort of say, well, older people are their problem list, which is exactly what the medical system does. And so that it's a deficit-based strategy as opposed to a more strengths-based strategy. What's your role in a strengths-based system? So for me, this has been a really kind of rich discussion, and I think lots of challenges for the organization to think about over the next year.
So from a Tivity's perspective, we look very much forward to partnering with more of the AAAs. We have some relationships, but what we're able to do is what we realize with our Medicare Advantage members and clients, they want it at the local level. So being able to tap into that, and then what we're able to do is we're doing it in Flint and some others, we can bring a class to the facility. So we could bring a Silver Sneakers class in there, have the class activated, and then we actually will generate revenue back for the agency because we pay them as a facility. In addition to that, we are also not able to bring a lot of our other things that we're doing. So we're building classes around social isolation, we're building classes around nutrition and diabetes with our Nutrisystem acquisition. So it's more than just being able to provide a physical activity, it's about the social and the nutritional components as well, which is what our clients are asking for.
You mentioned that you mentioned Medicare Advantage, and of course Medicare Advantage enrollment it continues to grow. Do you think about this beyond Medicare Advantage when you think about the future of your work with AAAs?
Well, yes. So it does. We do work with some Medicaid plans as well, but primarily our business is Medicare Advantage, and that's what we're focused on. That's what we build the business around, and we really become the experts as it relates to the senior population. So what we're trying to do is capitalize on that and make sure that we get completely understand that and be able to offer everything that we can there before we start venturing into things that we're not as much of an expert on.
If I would also add that I think an important role for the AAAs is advocacy. My own experience, I worked for a mayor for many years. I worked for 4 different governors, and I've talked to a lot of elected officials, and they, I think, are more inclined to think about the service needs of older adults in the Blockbuster model than in the Netflix model. They think of it as something, what did they know from 10, 20 years ago? I think the AAAs play a critical role in terms of helping policymakers to just really understand what those social determinants mean and how there can be changes that are helpful in terms of addressing those. We can point now to CMS saying, hey, this matters and you have to pay attention to that, but we want to make sure that local officials, state officials, and other federal officials all fully understand that, and that there's an array of funding sources and resources that become available. And I would just add an example of that I would also add in addition to CMS is we've begun working at the Federal Department of Health and Human Services with the Assistant Secretary for Health's office. And they're incredibly interested in the issue of social determinants of health, not just in CMS. They've been advocating that CMS should be paying for more, but also they're thinking about it through CDC, through SAMHSA, Substance Abuse Mental Health Services, through HRSA, for a wide variety of different federal agencies. How do we begin to get grant programs that could potentially result in funding to AAA agencies? But they've got to hear from you that these things matter, and they've got to hear what's not being funded that is critically important in terms of the health and well-being of older adults.
I want to pick up on that. I think that's vitally important to acknowledge the political aspect of this. It's very, very important, and of course, we're all pretty good at doing advocacy, but we have to do a different kind of advocacy here. A lot of our success in Ohio and working with health plans was based in political advocacy, because many times in a duals demonstration program, for instance, the framework of that plan under which the health plans have to operate is developed by the state. And so to the extent that you can have good relationships and you can make those kind of cases to state legislators, to state bureaucrats, it helps them to frame the issue in a way that's advantageous to the AAA. So that's a good point. You can't neglect the political aspect. The other thing I would say is that from a very practical perspective, the AAAs have to come up with creative business models. We know we can do the stuff, but can we develop and propose, not wait to have it proposed to us, can we propose business models that can aggregate regions and states? Because in many cases, in most cases, Medicare Advantage plans are not going to want to do just your AAA. They want to do the whole state. So in Ohio, we've come up with a mechanism to have a lead AAA subcontract, and that's now proliferating across the state. So we have a lead AAA subcontracting with Cleveland and Youngstown and Columbus and soon to be Toledo and Cincinnati and Dayton. So that's the way that the business model allowed us to go to the Medicare Advantage plan and say, yeah, we can do what you want us to do. We can cover your catchment areas. And those catchment areas might not be contiguous to counties, or I mean, that's just where their population is. So they may want a lot of service here and a little bit of service there. So you have to be able to figure out business models that will accommodate that.
That's such an important point, and this is the work that the N4a Business Institute is helping to support and helping to set up. So I've got one last question. It's for each of you, and it's on behalf of everybody who's in the audience. You know, thinking about the discussion we've had and the changes that we want and the changes that we see coming down the pike, how can the organizations in the audience, AAAs, other community-based organizations, collaborate with your organization to advance this important work?
I'll start. I'll just say, if you have not reached out to the Aging and Disability Business Institute, you need to. And I really want to build on what Gary has suggested, which is I fundamentally believe, we at the SCAN Foundation fundamentally believe in a proactive strategy. Just observe it's hard because it's asking you to take what you do and maybe do it in a different way. And it operates differently than the way some of the traditional block-granted federal funding flows. And so in another life, having worked in a major health plan, I can say, we're not into waiting lists and first in and first out. There are access standards. Plans have to be responsive. You're now participating in a medically oriented delivery model, which requires a different set of responsiveness kind of criteria than maybe available in other programs because you're trying to achieve certain kinds of outcomes. So I think that the Institute provides a really important vehicle for building your skills and testing out where your opportunities are. And then I just encourage all of you to work with each other and try. Like, this is a place where taking a little bit of risk and learning from it is super important. So
That's great. Thank you.
I'll just say, from the AAA side, AAAs have to have confidence in their core competencies, and I think they do. I said this yesterday at our meeting. What is it that you can do and do well? Mostly it's service provision. You might not be able to handle all of the business aspects. You might not have an IT platform. You might not have a shrewd business analyst to do cost accounting. You might need these other things, but other AAAs can help provide those things. But if you have confidence in your core competencies, you can figure out a business model when you collaborate with each other that will work. As I said yesterday, I give it the mom test, right? I can go to any AAA, big or small, and say, would I be confident in them taking care of my mom? And I would say, absolutely. And I would probably say absolutely to anybody in this room. You can take care of my mom. That's what you're selling. Now, how can you collaborate with each other to develop business acumen, business models, to then take that forward to the next step?
You've set a great example.
From our perspective, so a couple things that we can do. There's a lot of talk, Gary mentioned it today, there was talk yesterday about contracting with Medicare Advantage plans. And if you've never worked with a health plan or a Medicare Advantage plan, it could be a little intimidating. We have 70 Medicare Advantage plans. We understand it. So as we're talking and interacting with the agencies, be more than helpful in any way we can to try to educate or make some introductions. So that's one way. The second way is to be able to actually put classes, whether it's a fitness class or nutrition class, in an agency and generate revenue back for them. Because we will, as I said earlier, we pay them just as we would pay a LA Fitness or an Anytime Fitness. So it's a collaboration from that standpoint. And then we're also meeting with the group, the n4a, the leadership, to try to figure out how can we partner at a broader perspective than just on the local level.
That's fantastic.
I would say think about making the linkages at a larger, in partnership at a larger level in your community. And that could be, we're working with public health. It's still at the beginning of that effort, but with support from the John A. Hartford Foundation. In the next few years, we think every state is going to have public health departments that are reaching out to you with humility to say, we're here to help, let's figure this out together. In the short term, there also is great work that's being done around age-friendly communities through the certification process with AARP. And those deal with a lot of the same issues I've been mentioning. They really start thinking about different domains, from transportation to work to recreation to housing opportunities. And so getting the ball rolling by talking to AARP about what it would take to have your community become an age-friendly community is a good start as well.
That's a great point. Tina, did you want to add something?
So I think when you think about wanting to collaborate with health plans, and you're either a community-based organization or your AAAs, you really want to understand the states, how they break up their administrative regions, right? And then you're looking at your own internal resources, how they are all mapped out. and then what can you offer in each of those regions? And then from there, you can say, okay, you know, this is what we have collectively, and this is what we can, this is our infrastructure, this is our capacity. And then how are you going to collect the data? You know, you really have to consider internally, what is your data? And then what could possible outcomes be if you're going to address a population that's being served?
Very practical steps to move forward. Fantastic. Well, I'm so appreciative of all of you being here and offering your incredible insights and experiences, your perspectives on the work that we're all doing together by working together and building these cross-sector partnerships among health systems, healthcare payers, and community-based organizations. I really think that we can make a difference in the lives of the older adults, and that's where it's at. That's what's so important. I think that Sandy's going to come up and lead some questions from the audience, but I want to personally thank all of you.
Thank you. Thank you.
What a great panel. And this incredible panel has raised a lot of different issues, and I am hoping that there are some questions out in the audience, and we have time for just a few, but if you have a question for Rani or the rest of the panel, you know, please raise your hand. We have mic runners, and you might have to shout out because up here with the lights, I can't see you. All right, we have a question here in the front.
From the audience.
From the audience.
Hi, Deborah
Deb.
Stonewalls from Maui County Office on Aging. What advice would you give to AAAs just starting out in this work?
Besides starting with the n4a Business Institute? It's a great resource. I mean, that is the #1 step I would suggest, but there are many more in terms of collaboration and partnerships that others can speak to.
Well, I think a couple, and Gary started to hit on them, and maybe you can help add. So I think from the work of the foundation and sort of my life working in a health plan in an earlier phase of my career, I think I'd start by doing exactly what Gary said, which is like take stock of your strengths. I'd begin with what is it that you do really well, and feeling confident about what that is, how you could organize it, how you would talk to a health plan or another health systems provider about that would be really important. And then I would really try to take some time, maybe with your colleagues, other organizations around you, to understand what that service delivery area looks like. Take a little bit of time to learn about how the healthcare is organized in your community, and how is it one system or multiple systems? How do the health plans organize and pay for care? And that information should be sort of readily available, at least as a sort of a first order piece of learning, because then I think when you sit down with the folks, say at the Business Institute or your colleagues, or you sit down with a local plan or health system that bears some kind of risk, whether it's capitation or fee for service, you can begin to think about, so how do I fit in that ecosystem, that payment ecosystem and that delivery ecosystem?
I would say, agree. The other thing I would say, just as a very practical matter, and I don't know about your particular state, but a real key to making progress here is having a strong state association. In Ohio, we have n4a. Many of you know Lark Ritchie, who's here, and who's been a wonderful leader. That state association becomes the forum and the catalyst for the discussions that can help you move forward as a state. It's really hard to move forward alone, because Medicare Advantage plans are not looking for county level or regional, sometimes regional, but they're not looking for that. They're looking for stuff that you can do in collaboration with other, I want the AAAs to do this. The way to solve those problems and the way to match skill sets. We do this well, we do that well, is to have a strong state association. So if you have it, good. If you don't have it, or if you have one that's not strong, make it stronger.
Any other comments from the panel? If not, another question from the audience?
I see a hand over there. We can actually see it through the lights.
Yeah.
Good morning. Thank you very much for your information. I'm Brenda Clack, and I'm on the board in Flint, Michigan. My question to you is, do you feel there might be a relevancy in having a direct contact with the medical forces in our city and connecting them with the board? Not only the medical services, but the Board of Health, I think, is where I really want to go. Should the Board of Health directly in our city be connected in some kind of way with our AAA?
Well, I'm happy to speak to that. I would say yes. My own view is boards of health and public health departments have an obligation to serve the needs of the members of their community, all of the members of the community, with a particular focus on people who are more vulnerable or have complicated health issues or social conditions in their lives. They haven't always done that, but it is part of the mission, and it should be done. And at a national level and at state levels, efforts are being made to provide training and support and encouragement for boards of health and public health departments to be engaged in that way.
Thank you.
And if there's one more question, we might be able to take it in. Over here.
Yeah, hi. I'm one of thousands of workers with CDC, the nation's public health agency, and I want to compliment all of you on your efforts to partner with public health. With the nutrition, physical activity, and obesity program, so as I'm interfacing and trying to figure out how my work might support the N4As and how they might in turn help with our work, certainly age-friendly communities and livable communities resonates with me. But in terms of public health, I have colleagues in the injury division and fall prevention, brain health group. We have another division and center with disabilities. So there's a lot of things going on in public health that I think, depending on what your focus area is, you'll have to define what types of groups that you want to work with in public health. And I was just wondering if there's some consideration of all the areas of public health and how they can interface with the N4As, because it could get a little complicated in terms of a lot of us are spread all over the place in terms of different areas.
Well, one thing I would say is CDC does amazing work. I used to work at CDC, and I think what I would say is part of the changes that we need at the national level is we need to build a strong, integrative, healthy aging unit at the Centers for Disease Control. And when I worked there, I was always surprised that out of more than 12,000 people, there was really only a relatively small number of people who were working on issues related to older adults and healthy aging. So part of, I think, what we're working on at the national level is build that strong unit at CDC with sufficient funding so it can then give grants out to community agencies and to local and state public health departments to do that kind of integration of those various public health programs in ways that become more accessible and are more linked up with the AAAs.
Wonderful, and to the gentleman from CDC, we would love to partner with you. So I'll see you after this session for sure. I want to thank the audience for their questions, but I really also want to thank this incredible panel who have really ignited discussion and about the possibilities and the realities that we're seeing on the ground within area agencies on aging and working collectively with healthcare systems. We're doing a lot of work in that space now, but what you've heard is we need to do more, and we have the ability to do more. And with the support of the John A. Hartford Foundation, the SCAN Foundation, working through the Aging and Disability Business Institute, we're here to help you do more. And with that, I want you to know from N4A's perspective is that we want to make sure that you are not the Blockbuster, you are the Netflix. So with that, again, thank this incredible panel. Yeah, there you go. And thank you, Rani, for being with us today and sharing the vision and also all of the support and the direction of the John A. Hartford Foundation in supporting business acumen and supporting the AAA's movement in this regard. I'd like to invite you back to the podium for another exciting announcement showcasing the work of innovative community-based organizations that are leaders in doing exactly what we were talking about, bridging the gap between healthcare and social services and contracting with healthcare entities. So Rani, come back to the podium.
Thank you. Thank you. That was a great panel. Okay. So I'm really excited about this part of this morning's presentation as well. The John A. Hartford Foundation's Business Innovation Award was established by the Aging and Disability Business Institute in 2016 to highlight the success of community-based organizations that have partnered with healthcare entities. It's now more important than ever to identify innovative and effective programs that help people to receive the medical, social, and behavioral services in a really, truly coordinated way, a way that improves outcomes for older adults and people with disabilities. Today, we're going to be recognizing 3 community-based organizations that have taken bold, transformative steps to partner and contract with healthcare entities, ultimately improving the quality of life of older adults and people with disabilities in their communities. We have 2 runners-up this year. Our first runner-up is Appalachian Agency for Senior Citizens. Appalachian Agency for Senior Citizens PACE program, All Care for Seniors, was instituted in 2008 as only one of 15 rural PACE programs in the nation and one of 2 rural programs in Virginia. The program began with 8 members. And the relationship with AASC allows the PACE participants to receive a coordinated set of services as an alternative to nursing home care. Participants also receive value-added services from AASC, such as case management, nutrition services, and adult daycare services, all services you'll be familiar with, that help prevent isolation and loneliness due to the shrinking number of family members who are available for support. Funding is based on capitated rates, and it's a managed care program where PACE is both the insurer and the provider. PACE takes the place of the participant's individual medical plan under Medicaid and Medicare. PACE now generates over $8 million in yearly revenue and serves approximately 140 participants per year, an average of 100 participants per month. So I would like to invite someone from the PACE Appalachian Center to come join me. Congratulations and great work. Oh, Our next runner-up is Camarillo Healthcare District. The Camarillo Healthcare District is a public agency formed in 1969 to provide meaningful, effective, integrated community-based services that optimize health and wellness for residents of Ventura County in California. In 2018, the district served over 600 older adults, people with disabilities, and their caregivers through multiple contracts with health plans, hospitals, and physician groups and community partners as well. The district works in close integration with its medical partners by providing in-home care management and linking clients to services that address gaps in care while empowering clients to manage their health. Focused on quality, the district was an early adopter of NCQA certification for long-term services and supports case management and received the highest designation. They continue to strive to be innovative in their services and to act as strong advocates for community-based care. So would someone from Camarillo come join me? And this year's Business Innovation Award winner is the Institute on Aging. The Institute on Aging, in partnership with Brilliant Corners, the San Mateo County Health System, as well as nonprofit housing organizations and the Public Housing Authority, delivers a community care settings pilot. This program provides community alternatives to institutional care for Health Plan of San Mateo members with a focus on dual-eligible individuals through the framework of California MediConnect, a demonstration that aligns costs and savings between Medicaid and Medicare for those who are eligible for the program. The program itself strives to increase the quality of life and health outcomes of the Health Plan of San Mateo members to reduce health care plan costs associated with those living in the institutional environment and creating movement within the hospital and skilled nursing facility sectors so that the people with emergent and high needs can receive the necessary care. Existing resources are blended and braided together to provide a wraparound service that's needed to support independent living. Since the program began, at least 270 individuals have successfully transitioned to the community, roughly 50 per year. The partnership has now demonstrated that it can succeed at scale and that its support helps people to thrive in their community over time. So longevity in the community is at 93% and cost savings are also sustained. As a result, the model is currently being replicated in other Medi-Cal Connect communities throughout California. I would like to invite Dustin Harper to come join me to receive the award. Congratulations again to the Institute on Aging, Appalachian Agency for Senior Centers, and the Camarillo Healthcare District for their well-deserved honor. In addition, I want to recognize all of this year's Business Innovation Award nominees. We had a tremendous crop this year, more than double what we've had in previous years. So it made it not only a difficult decision, but really showed the growth in the work that you're doing. You're all doing incredible work, and we want to recognize that, recognize all of you. So those nominees who are here with us in the room, in the front of the room, please stand. Where are you? Maybe I can't see. We know you're there somewhere. So I'm gonna hand over the mic to Sandy.
Thank you so much, Rani, and thank you to the John A. Hartford Foundation. And again, congratulations to the award winners of the John A. Hartford Award. For all of them, if we could give them one more round of applause. And now I would like to welcome to the stage n4a's incredible president, Deborah Stonewalls.
Thank you, Sandy. Every year, the N4a president has the distinct privilege to honor a colleague in the Aging Network who has helped advance N4a's mission by bestowing the President's Award. I'm a little nervous about this one because I'm excited. The President's Award enables me to honor an individual who has shown a deep commitment and passion in serving older adults. Now, this individual that I've chosen this year, I think many of you will know, it's a rather shy person who does incredible work. I'm lying about the shy part. She's extremely outgoing. Yeah. And never hesitates to fight for seniors, whether it's for food, for dignity. She fights for her staff. She speaks up. She stands out. She does incredible work in the field. And I happen to be known as her mini-me, Mary Beals-Luedtka. So, Mary has been with the Northern Arizona COG for 28 years and has served as the director of the Area Agency on Aging since 2004. See, I knew I'd cry. She served from 2006 to 2015 on the N4a Board of Directors, and during that time was elected treasurer, second vice president, and first vice president. She was also a delegate to the White House Conference on Aging in 2005 with both a congressional and gubernatorial nomination, and was chosen to attend the White House Conference on Aging at the White House in 2015 by the President of the United States. She's somebody. In Arizona, she serves on the Arizona Age-Friendly Leadership Team, the Dementia-Friendly Arizona Task Force, as well as co-chairing n4a, the Arizona Association on Area Agencies on Aging. Mary continuously advocates and works for better services and supports for older adults. She's a strong advocate for rural Arizona and for all of rural America. The agency has grown considerably under her tenure, and she continues to work for better efficiencies, stronger partnerships, and increased collaborations to better serve older adults in Arizona and throughout America. So, Mary, it's my pleasure to honor you. Oh my God. Thank you. And now you get to say a few words.
It is such a great honor to be standing here. I'm very humbled by this award. Thank you, Deb. I think one of the most important things for all of us is to be able to inspire others to be more, to inspire others to take up that cause. And that's what we need to be doing right now together. And once again, I thank you.
Oh my gosh, you're making me shake. I'm shaking. Oh, thank you so much.
think it's you again.
All right. We're both a little verklempt. I'm truly happy that we can honor and celebrate Mary. And please, if you don't know her, get a chance to know her. She truly is an incredible leader and will go out of her way to help anyone. So get to know her. She's great. There's not a more deserving person. So thank you for this opportunity to honor her.
Wonderful. Deb, thank you. Wow. As we end this session, what an incredible note to be able to honor an incredible leader. But I really want to thank all of our panelists for such an outstanding commentary today on how we can move all of our network forward. I'd like to thank Rani and the John A. Hartford Foundation for continuing to support N4A and our members in the shared mission of improving the lives of older adults. And I'd like to congratulate all of our award winners. I also now want to make a couple of brief announcements because we're near the end of the session. I want to tell you some exciting things that are happening today. All AAA, but before I do that, I got to give you an assignment, right? A little homework while you're here in New Orleans or as soon as you get home. All AAA directors received the 2019 National Area Agency on Aging survey in their emails in June. So that was a while ago, you guys. The survey is the foundation for N4A and ACL to tell your story. And we've heard a lot during this conference about the importance of telling your story. As part of the last survey, what we found out, we were able to let policymakers and key stakeholders know that 63% of area agencies on aging were involved in integrated care delivery systems. And 70% of AAAs have taken steps to develop livable communities for all ages. Both are issues that have been front and center in our discussion this morning. These statistics, along with other data from the AAA survey, help N4A and ACL to tell your story to policymakers. And that also helps you tell your story to your state representatives and your local elected officials as well. The last survey was conducted in 2016. That was a long time ago when you look at the evolution of the work that we're doing collectively in the Aging Network. So I am asking you, please take the time to complete this survey if you haven't already within the next 2 weeks so that we can include you in the survey results. Also, I'd like to point out if we get a sufficient threshold of results from AAAs in your state, that we can develop state-specific reports for you that show and note the trends in your state from your agency and your colleague agencies there. I also would like to encourage you and remind you of the advocacy message that Amy gave so boldly yesterday, to get loud. And you've heard the importance of advocacy again throughout this conference. So please, please remember the important role that you play in advocacy, and remember that in the Older Americans Act, we are mandated to advocate for older adults. So a couple of highlights of some sessions I want to make sure that you're aware of. On the advocacy front, you have a chance today. The Elder Justice Coordinating Council listening session will be held this afternoon from 2:30 to 3:45 in the St. James Room on level 3. Lance Robertson will be there, Andy Mao from the Department of Justice. They want to hear from you, from AAAs and Title VI programs. What are the important elder justice issues facing you, your agency, and your communities? Next, there are a series of workshops that present new business opportunities for AAAs, just the things we were talking about in this morning's panel. 2 of our preferred providers, Active Daily Living and T-Care, will discuss caregiving resources that can drive revenue streams from 10:15 to 11:30 in the magazine room. That's on level 3. Also, Edenbridge Health and Excellence in Leadership Award winner Regina Sayers will be presenting on the PACE program, PACE and Your Agency. And the program for all-inclusive care for the elderly delivers value for clients and the community and your agency, and that's from 10:15 to 11:30 in the Fulton Room. And finally, join the Valley Area Agency on Aging and Tivity Health to learn more about fitness programs and how they can generate revenue for you through the Medicare Advantage supplemental benefits. That's 2:30 to 3:45 in the Fulton Room. You'll find more information on the conference app about all the incredible sessions that are going on in this at the conference today. And also you'll find more in your conference bag about N4A's preferred provider programs. So once again, as we close this session, I'd like to have you thank Aetna for their sponsorship of this session, and thank you so much for joining us today for this dynamic discussion. Have a great day, and we'll look forward to seeing you in all of the sessions today. Thank you.